This conference will now be recorded.
All right, so we're going to cover chapter 34, which is environmental emergencies. Let's get started with this. All right. So obviously with environmental emergencies, we're in that time of year now where the cold weather is starting to come in. Depending on where you work, that's something, definitely environmental. So I just recently had one cross-country skiing incident on Tuesday. So yesterday we had an incident with a femur fracture out in the woods on a trail. But with that being said, though, we're in that time now where we're going to start seeing cold-related injuries, sports stuff, skiing, things like that. That could be exacerbated by weather, terrain, atmospheric pressure, whether it be high altitude or underwater issues as well. Things that we might run into, maybe not underwater now, but we do have a lot of lakes and ponds, ocean stuff, depending on where you work, where you live. So there's a lot there. So a variety of medical emergencies can result, particularly in children, older people, people with chronic illnesses, and even young adults who overexert themselves as well. So the environmental effect on morbidity and mortality increases with stressors that induce or exacerbate other medical or traumatic conditions. So some of the factors affecting exposure would be thermoregulation. So thermoregulation is the balance between heat production and heat excretion. So we have thermoregulators within our system. So these rise in core body temperatures elicits responses that increase, heat loss and shut off normal heat production pathways, which is called thermogenesis. All right, the decrease in core body temperature prompts heat production and conservation and turns off normal heat liberating pathways, which is called thermolysis. So some of the factors of exposure, obviously physical condition, right? So if you're a fat guy, well, you tend to stay warmer longer outside because you have a lot more fat stores to keep you warm. Age plays another big part as well. As we get older with age, right, we start losing a lot of our muscle mass, our bone density, things like that could make us colder faster for that kind of exposure. We can become hypothermic faster as well, versus young age, neonatal into pediatrics, where they don't have a lot of muscle mass. We don't have a lot of muscle mass, where they don't have a lot of muscle mass, as well as bone density is smaller. They don't have a lot of blood volume inside to keep them warmer, things like that. So they can become exposed to conditions where they can become hypothermic faster than an adult would. Obviously, nutrition and hydration also play a huge part in that as well. And also the environmental conditions. I mean, are we in a hot environment? Are we in a cold environment? So with a hot environment, as you look at the, stand by a second here, see if I can get this back up. All right, we look at the hot environment here with these. The hypothalamus is stimulated when blood vessels dilate, maximizing heat loss from the skin, body sweats, causing evaporation and cooling. So our body will start to sweat for us to cool down. Where in the cold environment, the hypothalamus gets stimulated where blood vessels start to constrict, minimizing heat loss from the skin. Then we start shivering, generating heat. That's our body's mechanism of the thermoregulators, that thermogenesis and thermolysis that we talked about in the last slide, where our body starts to warm and or cool itself. The problem with that becomes the problem with that becomes or lose the ability to shiver when we severe hypothermia or severe hypothermia, right? And those conditions do exist, which is why it's very important to make sure we get true temperature measurements to see how these patients are going to, as far as their survival factor goes, and how to warm and cool patients as needed. on a second here. All right. So with cold exposure, the normal body temperature must be maintained within a narrow range for the body's chemistry to work efficiently. What is our normal body temp? All right, so I got 98.6, exactly. Now, some body temperatures might run around 98, some may run around 97. You might see some patients that live in like the 99 range, right? But still, that's normal. It's when we start seeing the temperatures change, so hypothermia, where the core body temperature falls because of inadequate internal heat production or thermogenesis, excess cold stress, or a combination of both. We start seeing that our body can lose heat, right? So we're losing heat through conduction, convection, evaporation, radiation, respiration, right? As we're breathing faster, we're expelling moisture through our respirations, causing our body to cool. So the rate and the amount of heat loss or gain by the body can be modified in three different ways. We talked about the increase or decrease heat production, right? So our body's cool, we shiver. We can move to an area where heat loss is decreased or increased, and we can wear appropriate clothing for the environment outside to keep ourselves warm. So there's charts that can be utilized through the National Weather Service and things like that for the wind chill factors. And as you can see, as the wind speed picks up, the temperatures tend to drop. So we have our actual temp outside, then we have our temp with the wind chill. And it's no different than looking at the heat indexes as well. Looking at relative humidity based on temperature. So you can see that if the relative humidity is 55 and it's 88 degrees outside, it's going to be as equivalent to being 93 degrees with the heat index, with relative humidity based on the heat index, right? So that we can look at different things like that as well. You can see some of the extreme danger situations looking through the higher numbers based upon humidity outside. So being up here in New England, we're not going to see this high humidities versus high temperature. But you get down to like, Texas, Arizona, or Arizona's more dry, more towards Florida, things like that, where you can have, 90% humidity in a 90-degree day, and it'd be like 113 degrees outside, right? So that can cause a patient to become hyperthermic very quickly. It's so different than being up in New England in the middle of winter when it's negative 10 outside and you have go back a slide here, right? So when it's, temperature is negative 10 and the wind's blowing at 40 miles an hour outside, looking at negative 43 degrees with the wind chill, right? That could be detrimental to a patient as well. So we got to take this kind of stuff into consideration as we're trying to deal with our patients outdoors and how long the exposure has been there for. So the pathophysiology with hypothermia occurs when the body temperature falls below 95 degrees Fahrenheit, right? At this point in time, our body cannot regulate its temperature and generate body heat. So we start seeing that temperature drop 95, 94, 93, 92. And as it keeps going down and going into the different stages of hypothermia. There's 4 different stages we can be that we come in contact with. And some states have decent protocols, New Hampshire being one of them, where they have decent hypothermic protocols and different treatment plans. So to compensate, the body normally constricts blood vessels in the skin or it starts to shiver to compensate for that cold. So we start constricting vessels. We start noticing, like, if you ever have been outside in the cold and you go to like crunch your nose and it kind of stays stiff, right? Our capillaries are starting to constrict, getting very cold and cool, trying to conserve body heat, right? That's when we start seeing, frostbite going in, starting to kick in, that frost snip, frostbite stage, getting into the hypothermic stages. So many body functions begin to slow down as the cold exposure continues. And the longer we stay outside, the lower, or the body starts compensating more to the point where our heart rate starts coming down, our blood pressure will start coming down. And that's where that old saying goes, they're not dead till they're cold and dead, until they're warm and dead, right? because we got to warm this patient back up. So hypothermic patients. Now here comes the kicker for New Hampshire providers with the epi. Right, ACLS, which we didn't talk about in hypothermic treatment, but if we have a patient that's severe hypothermia, let's say they have a core body temp of like 91, 89 to 90 degrees, right? Our blood is going to become more thickened as the cooler we go than our body temperature. So if you're starting to administer all these medications for a patient in cardiac arrest that's significantly cold, right? When the body warms up, all that medicine you administered, epi every 3 to 5 minutes, then all of a sudden hits the heart all at once, right? So when you're working on a patient who's in cardiac arrest, who's got a body temp that cold to the point where they're hypothermic, that causes them to go into cardiac arrest, you got to be, the patient's very fragile at that point. So if they have no pulse, CPR is in progress, we continue with our CPR, we still do our defibrillations as needed, but we push one round of medication until the patient starts warming up. Right. So many body functions slow down as their cold exposure continues. This can develop quickly or it can be gradually. The temperature does not have to be below freezing for hypothermia to occur. We've seen hypothermic patients just being inside homes, being on the floor. We start losing that radiant heat, right? We start getting cold by laying on the floor itself. So the temperature, again, does not have to be below freezing for hypothermia to kick in. Right? Our body's temperatures stay at 98.6. But if it's 90 degrees outside, we're not going to become hypothermic. But if we're in water in New England in the summertime, and the water temperature is around 60 degrees, 60 to 70 degrees, our body temperature will start to drop as we're in the water, making us become hypothermic, even though it's 95 degrees outside with water temps in the low 70s to upper 60s. Our body will tend to get cold, right? And I've seen that in the water rescue classes that I've done in the past, where they've been in the water for long periods of time. They start shivering, even though it's 90 degrees outside. So the temperature doesn't have to be below freezing. But more common among geriatric, pediatric, and ill populations. Alcohol is also a common contributor in hypothermia because our blood is starting to become more thin. Therefore, it doesn't allow our body to heat correctly. Impaired thermoregulation can also occur with therapeutic use or overdose of sedative medications, tricyclic antidepressants, and benzothiazines as well. So looking at this chart here, signs and symptoms would be increase in severity of the core temperature starts to fall, which generally progresses through 4 stages. Remember I mentioned there's 4 stages of hypothermia. So to assess the temperature of the patient's skin close to the trunk or the core, so what we really need to do is we need to get that rectal temp. So rectal temperature considered the most accurate for assessment of hypothermia. So mild hypothermia, the core temperature is between 95 and 93 degrees. Moderate is between 92 to 89. Look at stage 3, which is 88 to 80. And severe hypothermia is going to be below 80 degrees Fahrenheit. So we have our different stages. Some of the recommendations when you start getting into stage 88 to 80 degrees, this stage here, we're getting into stage 4, is getting patients to an ECMO center to start utilizing warmer blood and circulating blood oxygen throughout the system. Over there, the patients have a higher chance of survival. So the closest one to the Ossipee Valley is going to be Portsmouth Hospital. Maine Medical Center has it too as well, Dartmouth. But the only 2 in New Hampshire that currently have ECMO centers is Portsmouth and Dartmouth Hitchcock. So if the core temperature continues to fall to 80 degrees, vital signs start to slow down. So at the core temperature of less than 80, all cardiorespiratory activities may cease, right? So apparent death, cardiac arrest, unresponsive on this level here. Right, so never assume that a cold pulseless patient is dead. Patients are not dead until they're warm and dead. Keep that in the back of your head. We're going to warm the patients up. Right? So if you have a hypothermic patient in cardiac arrest, get them in the back of the ambulance, crank the heat, start putting heat packs in high heat loss areas, warm fluid, start getting this patient warmed up, transport him to the hospital. All right. So with exposure and localized injuries, we have local cold injuries. So localized to exposed body parts of the body, any kind of cold, like frost snip as well. So what we do is we can immerse, like for a foot, or immersion foot, I should say, can result when exposed body parts become exposed to very cold, but not frozen at that point. So you can kind of see on the tip of the nose here, you can see the blistering starting to form from uh, cold exposure to the feet as well. So we look at this kind of stuff and we need to make sure we're starting to treat it. If there are blisters that are starting to populate, please do not pop them. Light wrapping over the top as far as treatment goes, and transport the patient to the hospital. So in systemic hypothermia, the blood is shunted away from the extremities to maintain core temp, which is why I said when we start getting cold exposure, we start feeling the cold in the cheeks, top of the nose. If our feet are exposed and they're wet outside, start noticing that the more distal extremities, like in the toes, will start losing the circulation, pulling that blood more to the core to keep the core warm. Right, that's when we start getting blisters as well. Both local and systemic cold exposure injuries can occur in the same patient. So frost nip and immersion foot. So frost nip often affects the ears, nose, and fingers and is really not that painful. Sometimes people can be outdoors and not even notice the difference. Immersion foot occurs when after prolonged exposure to cold water, where the skin is pale, like blanched, and cold to the touch. I got some other pictures of frostbite as well in the next photo. So frostbite, or the tissues start becoming frozen, you can see how they're starting to blacken here. It permanently damages the cells. The tissues are now frozen. If gangrene occurs, the dead tissue may be surgically removed. So significant frostbite to the fingertips, things like that, can cause them to actually remove digits because of the gangrene and that bacteria starting to build up, which can enter the bloodstream and actually kill you. This is identified as a hard, waxy feel to the affected tissue. As with a burn, the depth of the skin damage will vary. So again, just like burns, it can work its way down and closer to the bone. As far as assessment of the cold injuries, we want to make sure that we management would include stabilizing ABCs, preventing further heat loss. Wrap the patients up. If you have heat blankets, place them on the patient, right? Get this patient warm. All patients who are injured are at risk for hypothermia, okay? Even if, again, significant blood loss, right? So if we have a patient with a traumatic injury that has significant blood loss, that also, remember, the blood's what's keeping the body warm along with muscles and everything else and tissue, but that blood is what's helping that circulation to keep that body warm. If we have significant blood loss, start losing our blood cells and everything else, what's going to happen is the patient's going to start becoming hypothermic, which is why we talk about trauma management, about laying a patient supine, right, or at a 30-degree angle, so the body doesn't have to work as hard to pump fluid. And then secondly, we got to warm the patient up. Even if it's cold, even if it's warm in the back of the ambulance already for you, crank the heat and warm the patient, right? We got to prevent that hypothermia from kicking in. So obviously, scene size up, look at air temp, wind chill, weather, if it's a wet or dry outside. As far as our safety, and are we prepared to go out into those types of conditions? We want to ensure that the scene is safe. Identify any potential hazards or scene hazards or safety hazards as such as wet grass, mud, snow, icy streets, right? Because if we get hurt or get injured going to this, what good does that do for the patient, right? So we want to make sure that this patient is going to receive the most optimum care. So consider special hazards as well as avalanches if you're working in the mountains. Cold environments may present special problems as well. So you make sure you use appropriate precautions. Consider how many patients there are and summon additional help as quickly as possible. Look for the mechanism of injury and indicators. Again, if you see something that should be there, it probably is. You just need to find it. Or could something be hidden underneath the skin that we can't see, but the mechanism shows that there should be an injury at that point? We're going to form out a general impression looking at a primary survey. The chief complaint may be the only maybe only the patient is cold. And that could be masking or hiding another potential injury because of how cold the patient is, right? I've seen patients before that have gone to snowmobile accidents where they're hypothermic, and once they start warming up, now new injuries start to occur, right? And fractures, same thing, like fractures with swelling. Well, it's so cold outside, but it's actually going to decrease that swelling and keep things more normal, right? And they may not feel the pain there until they start warming up. So just kind of keep that stuff in mind as you're doing your assessment. Fully expose your patient, get all those clothes off, get the patient warm back up, start looking at your head to toe, and see if you see any injury patterns that should be there based on your mechanism of injury. So look at that full rapid body scan. And whenever a life threat exists, we need to make sure we treat it. If a chief complaint is simply just being cold, quickly assess the core temp, right? Put your hand on their stomach, take a feel, see if you can tell how warm the stomach is, right? And then we need to make sure we're getting temperature. We get an oral temp. If not, and they're unconscious, we need to make sure we get a rectal temp on them as well. We want to see how cold they really are, right? If the chief complaint is, evaluate the patient mental status using ABFU, and then if they're alert, if an altered mental status exists, it's going to indicate the intensity of the cold injury. Now, patients that are shivering, okay, if they are shivering, are they using energy? If a patient is shivering, are they using energy? Okay, so what do you think one thing we should do to check? What should we be checking on these patients that are expelling energy? Sugar, exactly, glucose. So even though they're not a diabetic, check a blood sugar because it could be also low as well because of the fact they've been shivering so much, they're burning off all that energy, could cause them to become hypoglycemic as well as being hypothermic. Take into account the physiologic changes that occur as a result from hypothermia, right, as things are starting to change. If you have a patient that has a pulse and they're in stage 3 hypothermia, right, be very gentle with moving them because their heart is at a fragile state as well. So any significant jolt, bump, you get the new EMT driving the ambulance to 100 miles an hour down the road, it might not be the best option for this patient because if any major bump could cause this patient to go into cardiac arrest, right? So everything's fragile. It's like handling glass with care, right? Things can change very quickly based on the physiologic changes because of that hypothermia. Airway breathing, if you believe the patient is in cardiac arrest, provide high quality chest compressions, right? Address the airway and breathing afterwards. This patient needs to have circulation.
Hey, Kevin, can I add something real quick?
Yeah, absolutely.
Something that I learned last winter, especially with snowmobile wrecks or like backcountry skiing accidents, snow pants can hold a lot of blood. Just to touch on further exposing patients, especially out in the middle of the woods, because we had a lady with a femur fracture up on Black Cap. We didn't fully expose the snow pants, but she had a ton of blood loss inside the snow pants that never came through. So just keep that in mind.
Yeah, thanks, Ben. It's a good note. A lot of these clothings have so much padding inside of these things for warmth and insulation that it's kind of like a retainer. It retains the blood, so you really don't even notice it's even there. So good point, Ben. Thank you. So if you cannot feel the radial pulse, gently palpate the carotid and wait up to 60 seconds before you decide the patient is pulseless. Now, that's how things change for us, right? We're taught to check for 10 seconds. Somewhere in 10 seconds, you don't feel anything, start. Hypothermia changes everything. So 60 seconds of checking before you start compressions. Some recommend that CPR be delayed or suspended in severe hypothermia. So assume shock is present and treat appropriately. If the scene size up mechanism of injury or chief complaint suggests the potential for bleeding, look for it. Like Ben mentioned, if there is external bleeding and they're wearing snow pants and other layers, it may be hidden. You're going to have to expose your patient to find it. If available, warm humidified oxygen helps. I don't know many services that actually carry humidified oxygen warmers in their ambulances, but some do. So Justin, you're here, right? Yeah, there you are. Does Lebanon still have that? You know, it's the only service I've ever known that's ever had heated, humidified oxygen. It doesn't. Okay. I know they used to have a system on one of their trucks back in the day.
Conway has it.
Conway does have it.
Yep.
So maybe that's something to think about as well when you have something like an hour carryout. They have machines that can humidify and heat oxygen, which will help warm the inside as well. So even mild hypothermia can have serious consequences and complications. So all patients with hypothermia require immediate transport and evaluation for treatment. So remember, gentle transportation is necessary because any significant jolt or movement can cause that patient to go into cardiac arrest. So if transport is delayed, protect the patient from further heat loss. Find a way to keep them warm. I can tell you those heat blankets work wonders. I used one yesterday on my patient out in the woods, and we got him warmed back up fairly quickly. We had a proximal femur fracture, and because of the warmth that was provided by the heat blanket, we're able to control a lot of the spasms that were going on in his leg. And between that and splinting, everything worked out pretty well. So again, he wasn't outside for very long, maybe a half an hour, and he was already shivering sitting in the snow. So it didn't take long. And yesterday it wasn't super cold out either. As far as history taking goes, investigate the chief complaint, obtain a medical history, be alert for injury-specific signs and symptoms, as well as pertinent negatives. Ask them: chest pain, shortness of breath, dizziness, nausea, vomiting, diarrhea, headache, blurry vision. Get into the habit of asking those pertinent negative or pertinent questions that may have a negative response or a no, I do not have this. Then document it. If possible, determine the duration of the exposure, how the temperature in which the part was exposed to, and the wind velocity outside. Right? We need to know how long they were outdoors for. That makes a huge difference. Right? Sample history, we already know what that is, right? Investigate the underlying factors: exposure to wet conditions, inadequate insulation or cold or wind, restricted circulation from tight clothing, or shoes or circulatory disease, past medical history, fatigue, inadequate nutrition, alcohol or drug abuse, hypothermia, diabetes, cardiovascular disease, what their age is. A lot of different things that come into factors when we start treating the hypothermic patient. Then we get into our secondary assessment and we look at the focused physical exam on the severity of hypothermia. How bad is this right now? And can we get them warmed up, and where do we need to go? If you're going to be transporting to a local hospital, give them a heads up from the scene that we have a severe hypothermic patient, can you get the bear hugger ready? Right? Hospitals have these in the ER, but it takes time to set it up. They got to get the machine out, get it plugged in, the special blankets, and they're not just out readily in the open. They have to go to different closets to get stuff. So telling them 3 minutes out with an ETA does not help them prepare. But if you give them enough heads up, they can start prepping for a hypothermic treatment. Vital signs may also be altered, and the effects of hypothermia and respirations may be slower and shallow. Low blood pressure, slow pulse indicate moderate to severe hypothermia. As things start to drop, our body's starting to cool. So determine the core body temp using a hypothermia thermometer based on local protocol. Right? The hypothermic thermometers are going to be rectal. Right? So you have to turn your patient to the side. The best way to do, if they can, is bend them at the knees. That way there you can spread the cheek open and be able to insert the thermometer to get a true core temp. Right? But the best option to do that is turning a patient onto their side. If you can't, it's going to be a little more difficult. Pulse oximetries will often be inaccurate because of the lack of perfusion in the extremities. So what else can we utilize to be able to check perfusion status? My favorite thing. Yeah, you can try the earlobe, Matt. It's not a bad thought. But what else can we utilize to make sure they're perfusing? End title. Yeah, exactly. Capnography. Right? But that's not a bad thought, Matt, to try the earlobe too. See if that works, if you have one of those available. You can also change the sensitivity levels in the Zoll monitors as well. And it's a one-time change, and then it resets itself after you turn it back off again. but you can change it to a higher sensitivity to see if they'll pick up cold hands. That's another option also. Reassessment, repeat the primary survey, reassess vital signs, chief complaint, all treatments, review those to see if anything's changing. You may have to do multiple core temp changes or monitoring as well. Some of the cardiac monitors have temperature probes, and you can stick a thermometer rectally and leave it there and have continuous core temperature monitoring, right? There are ways of doing that to help. Communicate all information gathered to the receiving facility. So emergency medical care for the cold exposure. Some general steps is remove the wet clothing, keep the patient dry. Please do not take all their clothing off outside in the freezing cold. Get them to the back of the ambulance, cut everything off, and keep them warm. Prevent convection heat loss as well, and remove the patient from the cold environment. So we're going to remove the patient from the cold environment to prevent any kind of further heat loss and to prevent the damage to the feet. Do not allow the patient to walk. Right? We need to make sure we're carrying these hypothermic patients and remove any wet clothing. I'm going to put dry blankets over and under the patient. So if you have a stretcher, right, if they're on a backboard, take them off the board. If you have on your stretcher, put down extra blankets first, so that you can wrap the patient back up after you get everything exposed. Right, once you get all their clothes off, down to the trauma naked, that way we can wrap them up and we can apply heat packs and heat blankets underneath to warm this patient back up again. It also doesn't hurt to put space blankets in there either, right, to help keep that heat from escaping, right? So other methods. Some services I've seen as far as even buying electric blankets, but again, if you use it on a patient, you got to clean them afterwards, right? But I've seen those. I've seen wool blankets before, but the disposable ready heat blankets, they get up to about 140 degrees and they work very, very well. If available, give warm humidified oxygen if you have that availability, and then obtain IV access and follow local protocol for administering fluids to a patient with hypothermia. Right, heated fluids work great as well, but you may need more than just what's in your IV warmer. So another option is taping heat packs to the bags, or just having your partner toss them in the vents up front and turning the heat on high in the vent to kind of warm fluids up a little bit better than just room temp. As far as handling the patient, we want to avoid pain or further injury to the skin. So do not massage any of the extremities or allow the patient to eat or do any use of stimulants. Right, so have them refrain from that. You don't start massaging extremities because that can cause more damage to the muscle than the tissue. For mild hypothermia, signs and symptoms will be alertness, shivering. They'll respond appropriately, and the core body temp will be between 90 and 95 degrees Fahrenheit. Our treatment is going to begin passive rewarming, but slowly. We don't want to increase their body temperature too fast. We're going to turn up the heat on high in the patient compartment, and if possible, we can give warm fluids by mouth. Right? But I don't know of any ambulance that truly carries warm fluids. But if you have the availability of something warm, and even something with a little bit of sugar is perfectly fine, but not high amounts to help replace some of that fluid loss. Moderate to severe hypothermia, begin active rewarming is the best accomplished in the emergency department, where they have the ability to put the bear huggers on and things like that. But we have the availability with ready heat blankets and things like that in the back of the ambulance to at least start that process. Local protocols may dictate the appropriate type of rewarming strategy, so follow your protocol books, whatever state you're practicing in. If you cannot get the patient out of the cold immediately, move the patient out of the wind and away from contact with any object that will conduct heat away from the body. Find a way to move them and keep them warm. If you're going to use a Stokes basket, take a patient out, line the Stokes basket with blankets underneath them too to prevent that heat loss coming through the bottom. Right? We're putting patients on backboards and Stokes baskets so we can drag or carry them, but we're not thinking about the fact that these baskets are plastic and they can pull heat out of your body. So you're going to have to wrap them up with blankets. If you have the burritos, they do make those as well. You can line them with the burrito and then put them around them and keep the patient very warm that way as well. So withholding and cessation of resuscitative efforts. If submersion perceived the arrest, successful resuscitation is unlikely. Trauma, alcohol overdose, or drug overdose could also result in a hypothermic patient. So effects of the hypothermia may protect the brain and organs if hypothermia develops quickly. Fixed dilated pupils or apparent rigor mortis and dependent lividity are not contraindications for resuscitation in severely hypothermic patients. You still have to make sure you warm them up before you call it. So instead of sitting on scene for hours on end, transport. Emergency treatment for the cold injuries, remove the patient from further exposure to the cold. We're going to handle the injured part very gently and protect them from further injury. Administer O2 if this was not already done during primary survey. Remove any wet or restrictive clothing over the injured part. If there is no chance of re-injury or if the transport to the ED will be substantially delayed, consider active rewarming. So with frost nip, contact with a warm object may be all that is needed. So something warm. With immersion foot, remove the wet shoes, boots, and socks. Rewarm the foot gradually. Please do not put them in scalding hot water. Right? Warm water, gradually warm the foot up. You want to make sure you splint the extremity and cover it loosely with a dry sterile dressing. Never rub injured tissue. As we mentioned before, it can cause significant damage to the nerve endings and the tissue itself, and it may not heal correctly, or they may lose complete sensation to that area. And do not re-expose the injury to the cold. Once you have it warming up, please keep it that way. All right, so with late or deep cold injuries, remove any jewelry or other potentially restrictive items from the injured part. So we want to make sure we cover the injury loosely with a dry sterile dressing. Nothing wet, obviously, because it's going to cool the patient down even more. But you want to make sure it's loose on there so it doesn't stick to the patient and cause any more damage. But protect it by wrapping it with a dry sterile dressing, but loosely. If there are blisters, do not break them. Do not rub or massage that area as well. Keep the blisters in place. And do not apply heat or rewarm that part if it's a deep or cold injury. Do not allow the patient to stand or walk with a frostbitten foot either, right? That can cause more damage to the foot. Evaluate for signs and symptoms of systemic hypothermia. Get a core temp as well, and support vital functions and transport promptly to the hospital, right? If there is pain, we can provide pain management. But other than that, really, it's a cold injury that has to be dealt with a surgeon in the ER docs. As far as rewarming in the field goes, if prompt hospital care is not available and medical control instructs you to institute rewarming in the field, we're going to use a warm water bath. Immerse the frostbitten part in water with a temperature of between 102 to 104 degrees Fahrenheit. Make sure you're constantly rechecking the temperature because you don't want it to be any cold. Water should never exceed 105 degrees. And you want to make sure you're stirring the water continuously. We're going to keep the frostbitten part in the water until it feels warm and sensation has returned to the skin. Once we're done with that, we're going to dress the area with a dry sterile dressing, right? And then we're going to expect the patient to report to you severe pain. So consider administering nitrous oxide or calling for a paramedic backup for analgesics, right? So if your service has nitrous, it's not a bad thing. All right, George, I just saw your message. It may be an option to warm up for frost nip, but again, as long as local protocol allows you to do so, you can use it because it is a dry to warm up. It is dry, so it does help. If that answers your question, I would follow local protocol with that as well. All right. Now, if you have to actively rewarm the patient for that part, never attempt rewarming though if there's a chance that the part may freeze again before the patient reaches the hospital. So if it's going to freeze again, keep it frozen until you get to the hospital. If you know you can keep it warm at that point, then we can start our transport. Cover the frostbitten part with a soft padded sterile cotton dressing. And if blisters have formed, do not break them. So remember that you are also at risk for hypothermia if you work in a cold environment. So the cold weather search and rescue operations are a possibility in your area. You need survival training and precautionary tips. So be thoroughly familiar with your local conditions. Be aware of existing and potential weather conditions and wear proper clothing whenever appropriate. And properly maintain and equip vehicle as well. So make sure you have everything you need for that type of weather pattern. So the search and rescue teams that we have out in the areas that I work in, right? I'm sure that they're all very well prepared, know how to handle the cold weather, right? We as EMS providers are not going to go miles into the woods when it's negative 20 degrees outside. They have other teams that are especially prepared for all that stuff. All right. So any questions at all with cold exposure? Do we feel okay with this? A lot of it's pretty much basic review. The only difference is IV therapy, cardiac arrest management, and pain management as well. Other than that, a lot of it's BLS review. Perfect. That being said, let's talk about warming things up. So heat exposure. So a normal body temp is 98.6 degrees. So when the body produces excessive heat, it'll try to rid itself of the excess heat through thermolysis. So the two most efficient methods to decrease heat are sweating and evaporation of the sweat and dilation of peripheral blood vessels. So when the body is exposed or generates more heat energy than it can lose, hyperthermia can result. So hyperthermia is a high core temperature, usually 101 degrees Fahrenheit or higher. Okay, doesn't mean they have to have a fever, it's just the body temperature getting that warm. So the pathophysiology behind this is when the body's mechanism to decrease body heat or overwhelmed illness starts to develop. So high air temperatures can reduce the body's ability to lose heat by radiation. High humidity reduces the ability to lose heat through evaporation. And vigorous exercise causes loss of fluid and electrolytes. Right? So heat exposure can cause heat cramps, heat exhaustion, heat stroke, and all three also may be present in the same patient depending on how that it worsens. So we talk about loss of fluid and electrolytes. What do we carry in New Hampshire and Maine that we could administer at the advanced EMT level to replenish electrolytes?
Lactator ringers?
That's it, 100% correct. We have ringers to help with that. Ringers is great replenishment. Now, we talk about patients like the heat exhaustion. Can we get them to drink as long as they're not altered, right? If we are doing that kind of stuff, we want to make sure we're giving them water. They talk about utilizing sugar and salt mixed into the water. But if they are using like Gatorade or something like that, we want to make sure that we half it so we don't overload them with the sugars to make it worse. But we mix it with 50-50 with water. All right. So there are other ways of replenishing this. Pedialyte is another good replenishment for dehydration as well. But if we're going IV fluid, there's nothing wrong with giving lactated ringers. So heat exhaustion also may progress to heat stroke. So what's another thing on top of giving IV fluids we should be doing with these patients? What's another assessment tool that we should be putting on these patients as well? Right? So we have end tidal, but what else do we miss? Yeah, George, you're right. Heart rate, 12 lead. Right? Let's get EKGs. At least a 4 lead to start, 12 lead to finish. And it's no different. Same thing with hypothermia. So let's go back to hypothermia just for a second, because I completely forgot to mention this as well. If you put a patient on an EKG, you might see extra beats. All right? It's what they call a U wave, right? Or otherwise known as an Osborne wave. So after the T wave of an EKG, you have the P, QRS, and T, you'll have an additional beat. And you'll see that in your severe hypothermic patients. It's what they call an Osborne wave or a U wave, right? So our next in-person class, if someone reminds me, I'll actually draw it out for you and show you. If not, look it up online as well. I don't have any pictures of it right now currently with me, but it's called a U wave or an Osborne wave for hypothermic patients. All right, back to high heat now. So persons at greater risk for heat illnesses would be children, geriatric patients, heart disease, COPD, diabetes, dehydration, and obesity. So patients with limited mobility as well. Alcohol and certain drugs also make a person more susceptible to heat, or hyperthermia, I should say, not just heat. And contributing factors include length of exposure, intensity of exposure, and the environment they're currently in. Preventative measures, obviously maintain an adequate fluid intake, acclimate to the environment, limit the exposure, and drink water continuously, right? So people working outside in high temperatures should drink water continually to replace what is lost through perspiration. It's the ones that continue to work that aren't rehydrating like they're supposed to that are causing patients to become hyperthermic. We start seeing them become very crampy, like heat cramps, right? Or it could go right to heat exhaustion, and we'll talk about those here in a few seconds. So heat cramps are painful muscle spasms occurring after vigorous exercise. So sweat causing a change in the body's electrolyte imbalance, normally with the loss of potassium, can cause significant cramping. So dehydration may also have a role as well with this. So now we're sweating out, losing electrolytes, becoming dehydrated, losing potassium, calcium, sodium, all this stuff that can cause us to start cramping up. Usually occurs in the legs or abdominal muscles to start. Eventually that can work yourself into heat exhaustion, which is also called heat collapse is another name. Most common illness is caused by heat, results of the body losing so much water or electrolytes through the very heavy sweating that hypovolemia starts to occur. So if we have a patient becoming hypovolemic, what other vital signs do you think we would see? And changes. Really, it's just the elevated body temperature to start. Cold, clammy skin with an ashen pallor, dry tongue and thirst, dizziness, weakness, and faintness. But the vital signs will still be normal for the most part. And normal is elevated body temp for heat exposure, for heat exhaustion. We're not going to see that tachycardia, tachypnea yet, right? But once we get into lost my train of thought for a minute. So we get a little more depth in the signs and symptoms. I want to go back to that for a second here. So the onset while working vigorously or exercising in heat, humid, or poor ventilated area environments, and then you start sweating heavily. So the onset, even at rest in older or infant groups, in hot, humid, or poorly vented environments or extended time in a hot, humid environment, will have that cold and clammy pallor, normal vital signs and whatnot. But maybe subtle to increase in core body temperature with some neurologic deficit. So symptoms may be solely a result of dehydration combined with overexertion. The other things to think about are symptoms that do not resolve with rest and positioning, may be a result of increased core body temp. So we got to find a way to bring that body temperature down, whether it be using a spray bottle or misting to bring their body temperature down, into obviously the cool, shaded environment, air conditioning as well. The problem with this is we don't want to cool them down too fast so they start shivering. Right? We don't want to get them to that other side. We have to cool down slowly, bringing the body temperature down so we don't cause more damage to the thermal regulators within the system. Heat stroke is the least common but most serious illness caused by heat exposure. This occurs when the body is subject to more heat than it can effectively remove. Where the body temperature rises rapidly to a level in which the tissues are destroyed with a substantial neurologic deficit. Organ damage also occurs in the brain, liver, and kidneys, right? So we can have significant liver damage, significant kidney damage with heat stroke to the point where they actually have to go through, they become an acute renal failure. And they may actually have to go through dialysis. So this can develop in patients during vigorous physical activity, when they are outdoors or in a closed, poorly ventilated or humid space. What we're going to see is a hot, dry, flushed skin. It's kind of like really red, hot and dry. So do not rule out heat stroke even if the patient's skin is moist. It still can be there. A patient can have heat stroke even if they are still sweating. So the first sign is a change in behavior. The difference between heat exhaustion and heat stroke is the altered mental status. Once you have a change in behavior, that's when we start going into heat stroke at that point. All right. So if you see that on a test, by the way, mental status change is the key indicator from exhaustion to stroke. Telltale sign, a patient is no longer perspiring as well. Classic heat stroke commonly presents in people with chronic illnesses. Exertional heat stroke commonly presents in people who are in good general health but have an increased core body temp because of the overwhelming heat stress. So recovery from the heat stroke depends on the speed in which the treatment is administered. So how fast can we get to the patient, administer these cooling procedures, and getting that patient back down to normal temp? So yeah, firefighters. Here we are wearing turnout gear with thermal layers inside, fighting fire in 100-degree weather, right, outside. Then we go into a building, 500 to 1,000 degrees indoors, fighting fire, and coming back out to, again, 100 degrees. And we're burning out, we're sweating. Exactly. This is why firefighter rehab is so important. A lot of people say, it's just rehab. I can go through 3 bottles. Okay. But your body still can't handle that for long periods of time. You still have to be rehabilitated. And that means just getting a quick set of vital signs and drinking some water before you go back to work again, right? Don't push yourself to that limit. So with the assessment of the heat injuries and the scene size up, we're going to perform an environmental assessment. What is going on? Where is this patient located? Looking for hazards and clues, and using appropriate standard precautions. Again, indicators of MOI, heat emergencies commonly occur during athletic events and practices, right? So football, baseball, depending on what type of season you're playing in, a lot of times, summer football camps, things like that, where they're wearing full protective equipment and they're pushing themselves to the limit, right? Those are the kind of sports related things, soccer, cross country running, track, anything that's going to be done in the summer months where it's really warm for up where we are, but even still year round in some of in the southern states, right? So you got to look for this kind of stuff. Overcooling can result in shivering, which generates more heat, right? So we don't want to have them shiver, messes with the thermal regulators. Now they're still hyperthermic, and now they're shivering, creating more heat. So consider calling paramedic or calling med controller for paramedic backup so we can help stop that shivering process. We have the ability to do that utilizing benzodiazepines to assist. So looking at the primary survey, we're going to observe how the patient interacts with you and the environment. We're going to perform a rapid full body scan. We're going to assess mental status using the AVPU scale. We're going to assess the airway and breathing and treat any life threats such as any kind of hemorrhage. Consider special precautions if trauma is a possibility. We're going to assess circulation and treat aggressively for shock, right? For signs of heat stroke, transport without delay to the appropriate facility. Get the patient lying down or even like a 30-degree angle, not completely supine. Start the cooling process. Get IV therapy. Start replenishing fluids, right? Cardiac monitoring, end tidal monitoring. All the different things that we have, all these tools at our disposal to help treat this patient. Come up with more diagnostic medicine so we can start treating the patient. So during history taking, obviously after the life threats have been managed during the primary survey, investigate the chief complaint. What is wrong with him? Why are we here? Oh, you have abdominal pain, right? So here's a question for all of you, since you guys can administer certain meds. What is the first organ to shut down in a patient who is in shock? And heat stroke is part of shock. Okay, so let me ask you this. You guys are saying the liver. If a patient is having a heat-related emergency, what is one of the first things they tell you? Usually. Okay, stomach cramps. So what do you think the first organ is that shuts down? Stomach. Exactly. So what's the medication that we can administer to this patient for nausea? You guys all got your med books.
IV Zofran.
Yeah, IV Zofran. The only thing is that Zofran is not going to work in this patient right off the bat. They're nauseous because their organ is starting to shut down, because that's one of the most least useful organs when it comes to someone who's in shock. So it starts pulling away from the stomach, causing that significant nausea. So truly, to fix that nausea to start is going to be IV therapy and cooling that body down, so that way there the body can start becoming more homeostatic. So they need to meet that homeostasis. Then if the nausea continues, right, then we can administer Zofran after that. All right. So you're right. We can use Zofran. Let's treat that with fluids first to see if we can meet that homeostatic situation. So as far as our secondary assessment goes, if your patient is unresponsive, perform a physical examination of the entire body. So if the patient is alert, perform a focused assessment. If they're not alert, we go a rapid assessment, and then go more detailed after that, doing a head-to-toe detail. Right? Assess for muscle cramps and confusion. Examine the patient's mental status, AVPU, oriented ×4, person, place, time, and event. Obtain vital signs, lung sounds, blood pressure, heart rate, pupils, respiratory rate, end tidal, SpO2, blood glucose. All the things that can have a patient, all the vital signs we need to check in a patient to see if we can correct one of those life-threatening conditions. Examine the patient's mental status, pay close attention to the patient's skin temperature, the skin turgor, and the level of moisture. The best way to check skin turgor is actually on the knuckles. So if you all take your hands and open them up and pinch the knuckles, right, if the skin stays up, then you're a little dehydrated, right? You can use the back of the hand, but if you do that, with an elderly patient, they're probably going to stand up at a tent anyways, right? So then check the knuckles as well. Perform a neurologic exam, okay? Stroke scale, right? Check it and do a full neurological assessment. Patients with hyperthermia may be tachycardic and tachypnic as well. So we're going to have to maybe control the respiratory drive, right? We're also going to check the patient's temp. Do an oral temp. If you need to get a rectal, then we get a rectal. Right? We want to see how high the temperature is and then continuously monitor that to see if there's any changes. With a reassessment, we're going to watch your patient's condition carefully for deterioration. Remember, even if you think things are getting better, it could be worse. Okay, it could get worse. So monitor the vital signs at least every 5 minutes. Set your monitor for every 5. If you don't have a monitor, then you have to reassess vitals every 5 minutes. Leave the blood pressure cuff in place and just reevaluate. Be careful not to cause shivering when cooling the patient down. Right? If you cause shivering, it's going to cause the patient to get even warmer. Call for paramedic backup, because there's medications that can be utilized, like Versed or benzodiazepine, to control the shivering. Document the weather conditions and activities the patient was performing prior to the emergency in your patient care report. How warm was it? If you have a heat index on your phone, document that. It's all part of the continuity of care, right? So these patients go to the small critical access hospitals and have to get transferred out. The trauma centers are going to want to know what was seen in the field, right? So you're going to have to get these patient reports done and make sure you document thoroughly. All right, so medical emergencies for heat cramps. Take the following steps to treat heat cramps in the field. 1, remove the patient from the hot environment. High flow oxygen if indicated, if they need it. All right, rest the cramping muscles, have them relax. Replace fluids by mouth if you have the ability to give oral fluids. Cool the patient with a water spray or mist and add convection by manually or mechanically fanning the patient. When heat cramps are gone, the patient may resume activity. Perfectly fine. Heavy sweating may also cause cramps to reoccur as well. So again, they need to be replenished. You got to give them the fluids that they need. The best preventative and treatment strategy is hydration by drinking water. Give them more water. So like Justin mentioned earlier, firefighting, right? They need to drink water, hand them water. If the cramps do not go away after these measures, initiate IV therapy line and transport the patient to the hospital, right? If you have to put an IV in someone to reduce heat cramps after you've exhausted all their efforts, then they need to go to the hospital for further evaluation because their labs could be completely screwed up, right? If you are uncertain that the cramps were caused by heat or you know anything out of the ordinary, contact medical control and have a consultation with them to find out what's next. Heat exhaustion. To treat the patient with heat exhaustion, follow the steps in skill drill 34-1 in your book. So treatment is really aimed at removing the patient from exposure to the heat and urgently reversing the increase in body temperature. If an ice bath or a similar facility is available, provide cold water immersion to the patient if allowed. Again, contact med control before you start doing this. But the clothes need to come off. We need to get them naked. We're going to start cooling them down. Right? Well, I should say naked. They can leave their boxers on or underwear, but get the pants down, shirt off, and start cooling. Right? Prepare to transport the patient to the hospital for more aggressive treatments if the symptoms do not clear up promptly, level of consciousness starts to decrease going into heat stroke, body temperature remains elevated after efforts of trying to cool the body down. If the person is very young, older, or has any underlying medical conditions, they need to go to the hospital for further evaluation. For heat stroke, recovery really depends on the speed in which the treatment is administered. So when treating the patient with heat stroke, we're going to move the patient out of the hot environment. We're going to set the air conditioning to maximum cooling. We're going to remove the patient's clothing and administer O2 as needed. Cover the patient with wet towels or sheets, or spray the patient with cool water and fan the patient to quickly evaporate the moisture on the skin. Obtain IV access and administer a 20 ml per kilogram bolus of an isotonic crystalloid solution, repeating as needed. Provide immediate transport. Notify the hospital as soon as possible. Give them a heads up from the scene that you're coming in with a heat stroke patient. Anything critical, the more heads up they get, the better they can plan for it. The last thing you want is to bring somebody in with a 5-minute ETA and they got to move patients out of trauma rooms to other rooms to make room for you. Give them a heads up. If anything, have dispatch call the hospital and say, hey, EMS is coming in. They'll give you a report en route, but they're coming with a heat stroke patient. They want to just give you a heads up so they can start prepping. Right? If you don't have the time to call right away on the scene, have dispatch do it for you. Right. So any questions at all with heat-related emergencies? No? Perfect. Right. It is now 7:09. So why don't we take about 5 minutes or so, get up, move around. We'll come back, and then we'll finish up with water emergencies and keep moving forward. Let's see you guys in about 5 minutes or so, 5 to 10. Let's do 10. We'll see you back at 7:20.
Okay.
This conference will now be recorded.
All right, so to continue on, water emergencies. So drowning, obviously respiratory impairment from submersion or immersion in a liquid. So patients with submersion injuries can die from secondary complications that occur beyond 24 hours. So we talk about that dry drowning, or that second, what they call a secondary drowning, which can occur up to 24 hours later after they've been in the water. What's happening there is that they've aspirated water into the lungs, and when they lay down at home, they become very lethargic, they become cyanotic, and that water that was sitting there can trigger that response, or it could trigger a laryngeal spasm later on, causing the person to stop breathing. Alcohol consumption also, pre-existing seizure disorders, geriatric patients with cardiovascular disease, and unsupervised access to the water are among some of the major risk factors for a drowning situation. So inhaling a very small amount of fresh or salt water can severely irritate the larynx, resulting in a laryngeal spasm. So think of it as the larynx completely closing up. All right. That way there it stays closed, causing the patient to become very hypoxic. Right, and they become hypoxic, puts them in the respiratory arrest, which will put them into cardiac arrest. So hypothermia is also a major concern with any kind of water-related emergency. Even if it's warm out, still the same. The body's diving reflex, or otherwise called as mammalian diving reflex, may also slow metabolism to the point of protecting vital organs. So if you're in cold water, mammalian diving reflex will cause the body to slow down. Bradycardia kicks in, blood pressure starts to drop to the point where the Mother Nature is saying, hey, I want you to keep your body alive. And hypoxia is always the first concern as we take water into the lungs. So diving emergencies are the most serious water-related injuries that are associated with dives. With or without scuba or self-contained underwater breathing apparatus gear. Some injuries are related to the nature of the dive. Others result from panic. Some physical principles of pressures effects as well. Pressures may be expressed in several different ways. Measurement in ATA is the most commonly used in diving medicine. I'll show you some stuff in the next slide here. Most scuba diving is done in depth between 30 to 60 as well, and liquids such as water are not compressible. So let's go through the slide here. So we look at the gases that follow physical laws. So Boyle's law, at a constant temperature, the volume of a gas is inversely proportional to its pressure. Dalton's law, each gas in a mixture exerts the same partial pressure that it would exert if it were alone in the same volume. And Henry's law is the amount of gas dissolved in a liquid directly proportional to the partial pressure of a gas above the liquid. This law explains decompression sickness, or the bends. So per Boyle's law, the volume of nitrogen decreases as pressure increases. Per Dalton's law, the partial pressure of nitrogen increases as total pressure increases as well. And Henry's law states that as pressure decreases during ascent, nitrogen comes out of the solution in the blood. So dive tables and dive computers provide guidelines for divers regarding when to take decompression stops during the dive, as you're looking here, right? So as they're coming up, they have to stop so the body can meet homeostasis at that level, right? They have to decompress as they're coming up in different levels, okay? If they come up too quick, all right, it can cause significant damage, the bends. You can also have nitrogen narcosis going down too fast as well. We'll get into that here in a second. I just want to go too far in depth yet. So the general assessment of the diving history. So we're going to obtain as many details as you can about the dive and the onset of patient symptoms. How long has it been going on for? So we're going to use a special form that records the following information. 1, when did the symptoms start? Symptoms occurring within 10 minutes of surfacing suggests an air embolus. What type of dive was done and what type of equipment was used, right? Was it a Was it a dive that went straight down without any kind of equipment? Was it a free dive, or were they using tanks? What type of tank was used? There's different style of tanks that have different gases for divers to go down into certain depths. Where is the diving site, and what was the water temperature going down? How many dives were made in the past 72 hours, and at what depth, bottom time, and surface interval for each? Was a dive computer used? Were there safety stops used at all? Were there any attempts at in-water decompression considered risky? Were they coming up too fast because they were losing their air? Right? Were there any dive complications? What were pre-dive and post-dive activities that were done? Right? So all this stuff plays a big factor. So descent emergencies are a major problem during descent is barotrauma to the lungs, to the chest. Barotrauma can result from compression of gases within the body spaces during descent, or expansion of gases within those spaces during ascent. So going down or coming back up. So as long as the air-filled cavities of the body can equilibrate freely, they will not implode. So a person with a perforated tympanic membrane may develop a special problem while diving. All right. So injuries at depth, down low, we talked about going as a descent, going down, is nitrogen narcosis, which is a state of altered mental status caused by breathing compressed nitrogen containing air at a depth, causing them to get completely crazy underwater because they have too much nitrogen in your system. Ascent or ascending emergencies, right? So the most serious injuries associated with diving are related to ascent from the bottom up, usually require aggressive resuscitation. So two particularly dangerous medical emergencies are air embolus for one, and second is a decompression sickness. So pulmonary overpressurization syndrome, or POPS, can occur when divers fail to exhale during an ascent, causing a pneumothorax, mediastinal and subcutaneous emphysema, alveolar hemorrhage, and a lethal air embolus. So patients that come back up, they get that decompression sickness. Where do they need to be transported to?
They need a place with a hyperbaric chamber.
Right. So they can get oxygen into the system to help with that decompression sickness. Right. So who has one? And the ones they use for wound care are not going to work. You have to find a true decompression chamber. Right. I can tell you there's anything local, not around here. Right. So that's the issue.
It's Mass General, right?
Yeah, Mass General has one. That's Boston. We're up in
Yeah.
the middle of the woods, right? We have
Yeah.
people passing through the lakes,
Or Maine Med, I'm guessing.
and we can't fly the patient. That puts them at a higher altitude. So there's Maine Med does not have one. They don't have a hyperbaric chamber for. They have wound care. So they don't have one for that. I know that years ago we had patients that required hyperbaric chambers. Over at CMC, they had in Manchester, they had a house with high levels of carbon monoxide, like thousands part per million. They had 7 patients that were unconscious. All of them got intubated, and they had to send them to hyperbaric chambers, and the closest ones were down in Boston from there. We're doing back-to-back vent runs. So pulmonary or POPs can occur while divers fail to exhale during ascent. This can cause the pneumothorax, mediastinum, subcutaneous emphysema, or lethal air embolus. So they have to exhale coming back up. So physical examination may reveal palpable subcutaneous air above the clavicles, so that Rice Krispies, right? subcutaneous emphysema. Signs and symptoms depend partially on where the escaping air ends up. So physical examination may reveal palpable subcutaneous air above the clavicles. Always look for unequal breath sounds, low pulse oximetry values, and hypersonics on the affected side of the chest. Excuse me. Treatment depends on whether the patient has an air embolus or not, as well, or a pneumothorax may require a needle decompression or a chest tube. So in the field, provide 100% oxygen via non-rebreathing mask and transport. And if you have a diving injury, make sure you notify the hospital early. Let them know you're coming in with a dive injury. Air embolus are bubbles of air that are in the blood vessels. So air pressure in the lungs remain at the high level, while the external pressure in the chest decreases. So air inside the lungs expand rapidly, and then air is then released from this rupture, can enter the pleural space or compress the lungs, the mediastinum, so they have like a pneumomediastinum, bloodstream, creating an emboli, or pneumothorax, or a pneumomediastinum, both result in pain and severe dyspnea. All these are life-threatening conditions. We need to get them to a hospital. The local hospitals cannot really handle these. They're going to get shipped to places that have pulmonary. Portsmouth Hospital can handle this for New Hampshire as one of more local. Maine Medical Center, obviously, yes, they can handle that as well for Maine. But Portsmouth is going to be one of the closest centers that can handle most of the stuff that's here. So potential signs and symptoms of an air embolus would be blotching or mottling of the skin, froth in the mouth or nose, often usually pink or bloody, severe pain in the muscles, joints, and abdomen, dyspnea, localized pleuritic chest pain, dizziness, nausea, vomiting, dysphagia, cough, cyanosis, difficulty with vision, paralysis and or coma, irregular pulse or cardiac arrest. With decompression sickness, bubbles of gas obstruct blood vessels. Results are from a too rapid of an ascent from a dive, or too long of a dive at too deep of a depth, or repeated dives within a short period. The most striking symptom of decompression sickness is abdominal and or joint pain. All right. So dive tables and small diving computers are available to calculate and record the proper rate of ascent from a dive. So a sudden decrease in external pressure of the body and release of dissolved nitrogen from the blood forms bubbles of nitrogen gas within the blood vessels, causing that significant pain. So very difficult to distinguish between air embolus and decompression sickness. An air embolus occurs immediately on return to the surface, where symptoms of decompression sickness may not occur for several hours after the fact. So treatment consists of oxygen administration, monitoring, and transport, followed by recompression in a hyperbaric chamber. So recompression or treatment allows the bubbles of gas to dissolve in the blood and equalize the pressure inside the outside the lungs. So that hyperbaric chamber, right, will bring the patient back to that pressure where they are perfectly fine. Then they have to, it'll take hours upon hours upon hours to get that patient back to normal, kind of going back through those different tours, going back through the different levels, so it helps decompress the appropriate way. But again, even still, patients can still die from this. All right. So as far as water rescue goes, again, unless you are trained and certified to go in and perform a water rescue at the technician level, we do not go in the water. So there are 3 different levels of operational capacity. The first one being awareness, operations, and technician. Awareness is kind of like just going through the motions, reviewing a presentation, learning about incident command, things like that. Operations allows you to do shore-based rescue and boat ops. And technician is when you put on a suit and go in. Those are going to be your go rescues for that. So water rescue and removal of the patient must occur when assessment and treatment. So the basic rules of water rescue are: first, try to reach for the patient. So reach, row, throw, and go. Go being your last rescue. So throw the patient a rope, life preserver, or any floatable object that is available to help them keep afloat. Next, use a boat if one is available, but do not attempt a swimming rescue unless you are trained to do so. So reach, throw, row, and go are the order of priority to get the patient out. If I can talk the patient out prior to reaching, great. But if not, we need to take the least risk method possible to get the patient out of the water. So be prepared for rapid hypothermia in the cold environment. Remember to warm your patients up. For colder areas, plan for ice rescue is also necessary. So when we live in New England, ice rescues are higher. We're not going to see those down in Florida. So success depends on how rapidly the patient is removed from the water and ventilated. All right, so spinal injuries and submersion. Keep in mind that spinal injuries are the fourth leading cause of injury or death in traumatic injuries. Is spinal, and usually head first entries. So spinal injuries from submersion incidents or submersion incidents may be complicated by spinal fractures. So assume that a spinal injury exists when submersion has resulted from a diving mishap or a fall from a substantial height. The patient is unresponsive and no information is available to rule out any possibility of a neck injury. The patient is responsive but reports weakness, paralysis, numbness, or tingling in the legs or arms. You suspect the possibility of a spinal injury despite what witnesses say. So we're going to stabilize the suspected injury when the patient is still in the water before we get them out. To stabilize suspected spinal injury in the water, follow skilled steps in skill drill 34-2. It's not simple backboarding somebody in the water and stabilizing. That requires training and repeat training to get it right. So again, before you stop hopping in the water and spinal immobilizing somebody, make sure you're appropriately trained to do so. As far as recovery techniques go, an organized rescue effort calls for providers who are equipped with recovery techniques and equipment, including snorkel mask or scuba gear, to be able to go underwater to do a search and recovery. Right? There's a lot of different methods of this. Nothing that I'm going to teach in this class, but if you took one of my water programs, it's all taught with snorkels and masks now. It's all part of the newer curriculums that just got released. How to do recovery techniques without using scuba gear. So as far as drowning and diving emergencies for scene size up, we're going to make sure the scene is safe. Make sure you use standard precautions. Never dive or never drive through moving water if there's any kind of flood potentials. Use extreme caution driving through standing water. Never attempt a water rescue without proper training or equipment. Call for resources, and if the patient is still in the water, look for the best, safest means of removal. Trauma and spinal stabilization must be considered in recreational settings. So check the additional patients depending on the situation and look at the indicators of the MOI. We're going to form a general impression, assess for life threats, and determine whether spinal stabilization is necessary. We're going to pay attention to chest pain, dyspnea, complaints of sensory changes when a diving emergency is suspected. We're going to utilize the AVPU scale and be suspicious for drug and alcohol use and its effects. Open the airway. If the patient is unresponsive, open the airway. If you suspect spinal, make sure we use a jaw thrust maneuver versus a head tilt chin lift. If the patient is vomited, or if it's pink frothy secretions are found in the airway, right, we got to suspect potential for fluid buildup in the lungs. We're going to provide ventilation to the bag valve mask for inadequate breathing. If a patient is responsive, right, with a near drown or drowning incident, and you hear fluid in the lungs, provide high flow oxygen with a non-rebreather mask. However, it is within your protocol. Now, this is New Hampshire and Maine stuff too. You can utilize CPAP if the patient can maintain their own airway. If there is no risk of spinal injury, position the patient to protect their airway from aspiration in the event of vomiting, and obtain continuously monitored breath sounds as well. These are patients you want to put end-tidal CO2 on and pulse oximetry continuous monitoring. We're going to check for a pulse. Never give up on resuscitating a cold water drowning victim, right? Exposure to the cold will also occasionally activate certain primitive reflexes, like mammalian diving reflex. So evaluate for adequate perfusion, and if the MOI suggests trauma, assess for bleeding and treat appropriately. Make a transport decision. Always transport patients to the hospital. Symptoms may not appear for 24 hours or more after resuscitation. All right, so again, get them to the hospital. Adult respiratory distress, or ARDS, ARDS, or renal failure may occur after resuscitation. So inhalation of any amount of fluid can also lead to delayed complications lasting days or weeks. Decompression sickness and air embolus must be treated in a recompression chamber, and all interventions must be done en route. So don't waste time getting to the hospital for these types of patients, because they're going to need definitive care at the ER to start. So as far as history taking goes, chief complaint, medical history, sample as well. Pay special attention to dive parameters, and note any physical activity, drugs, alcohol consumption, or medical conditions as well. So again, if you're having any question in regards to diving emergencies, you can call the DAN network as well. That's based out of Florida. The numbers should be in your protocol books as well. If not, you should have that number in your phone. In case you have a dive emergency, you need to call for additional, I don't want to say resource, but a consultation. As far as secondary assessment goes, if the patient is responsive to a focused physical assessment or examination on the basis of the chief complaint and the history obtained. So serious drowning situations typically result in an unresponsive patient. So these patients here that are unresponsive require intubation if they have a drowning issue because of the potential for laryngeal spasm, right? So paramedic level of care, call for a medic to have them come in. These patients, certain patients that require immediate intubation, drowning being one of them, and burn injuries to the throat, superheated gases. And obviously significant anaphylaxis with angioedema. Very important to begin with a rapid full body scan, and we're going to assess ventilations and oxygenation. So with this, end title, pulse oximetry, see what we have going on, and then make your assessment and determination how you're going to treat your patient. If the patient's hypothermic, let's warm them back up, get a baseline Glasgow coma scale, complete a detailed full body exam, and route to the hospital. We're going to monitor respiratory, circulatory, neurological compromise. So again, doing stroke scales and assessments, checking all the neurological functions, CSMs, the full deal. All right. We're going to assess for peripheral pulses, skin color and discoloration, itching, pain. All right. Looking for all that kind of stuff as well. We're going to check vital signs. Patients that have anything with a drowning or diving emergency, reassess vitals every 5. Listen over the chest for a heartbeat if the pulse is weak. Right. Listen to the atria and the ventricles, so high and low of the heart. Remember that oxygen saturation readings may produce a false or low reading due to the patient's stability, especially if they're cold. As far as reassessment goes, we're going to reassess vital signs and chief complaint. We're going to recheck the patient's interventions that we've done, and we're going to call for a paramedic backup early if a definitive airway is needed. Like I said before, drowning patients may require intubation right away, depending if they're unresponsive or not. So pay close attention to respirations and breath sounds, because things can change quickly, right? Especially for significant pulmonary edema. Document the circumstances of the drowning and the extraction of how the patient got out. All right. So as far as care for diving or drowning emergencies as well, patients should be kept warm. We're going to provide blankets, protection from the environment as needed, IV access, and cardiac monitoring. Do not delay transport for IV attempts. Right, try to get them en route. When treating a responsive patient who is suspected after having an air embolus or decompression sickness, remove the patient from the water. Administer oxygen via non-rebreathing mask or BVM assist. We're going to place the patient in a left lateral recumbent position with the head down. We're going to consider the possibility of a pneumothorax and monitor the patient's breath sounds for developing of a tension pneumothorax. We're going to provide prompt transport, and the key in the emergency management of this patient with these serious ascent problems is to recognize that the emergency exists and treating as soon as possible. Getting these patients to definitive care. If there is an air embolus, there's nothing we can do in the back of an ambulance to help with that. Right? They need to get to an ER and then go for further care from there. For submerged vehicle incidents, the safest time to escape from a submerged vehicle is immediately after it enters the water. So attempt to remove the passengers from the vehicle as quickly as possible if you can. But do not put yourself in harm's way where you're going to be dragged down on your own. Some other water hazards: pay attention to the body temperature of a person who is rescued from the cold water. Treat hypothermia caused by immersion in cold water the same way as you would treat hypothermia caused by a cold exposure. All right. Prevent further heat loss as well from contact with the ground, stretcher or air, and transport properly. So getting a blanket underneath the victim, wrapping around the victim, making sure that you dry them off, and applying heat blankets, heat packs, warm fluids to get this patient warmed up. If you have what they call breath-holding syncope, right, or they call hyperventilation or shallow water blackout, what happens is this lowers the carbon dioxide levels in your system, causing you to have a syncopal episode. This happens to swimmers who breathe in and out rapidly and deeply before entering the water. Hyperventilation does lower that carbon dioxide level, which is causing that syncopal episode. So swimmers may not feel the need to breathe even after using up all the oxygen in the lungs because of the hyperventilation. So treatment is still the same as it would be for drowning or submersion. Nothing changes in treatment. Injuries caused by water hazards may be complicated by immersion in cold, or injuries from boat propellers, sharp rocks, water skis, or dangerous marine life. Treatment: remove the patient from the water, protecting C-spine, oxygen administration. We're going to apply dressings and splints if needed. Monitor closely for signs of immersion or cold injury. Remember that a child who is involved in a drowning or submersion may be the victim of child abuse, right? So handle accordingly to laws regarding suspected child abuse as well. As far as prevention goes, appropriate precautions can prevent most immersion incidents, right? So we talk about pool prevention, all that kind of stuff, right? So pools should be surrounded by a fence at least 6 feet, 2 meters high, with slats no farther apart than 3 inches and self-closing, self-locking gates. The most common problem is lack of adult supervision, lack or lapse of adult supervision. So be involved with public education to make people aware of hazards. If you take a true water rescue program, this is all part of the same thing, except we go way more in depth on different prevention strategies following NFPA. All right, so any questions with water-related emergencies? No? Good? We all set? Awesome. So as far as high altitude goes, disbarment injuries, signs and symptoms caused by the difference between the surrounding atmospheric pressures and the total gas pressure in various tissues, fluids, and cavities of the body. So let's go more into here. So altitude sickness or altitude illness occurs when an unacclaimed person is exposed to diminished oxygen pressure at a high in the air at high altitudes. This affects the central nervous system and pulmonary system as well. So this range will range from the common acute mountain sickness, to the rare deaths from high altitude cerebral edema, which is HACE, or high altitude pulmonary edema, which is HAPE, so HACE or HAPE. So the acute mountain sickness is caused by diminished oxygen pressure in air altitudes above 5,000 feet. This results in hypoxia. So signs and symptoms would be headache, lightheadedness, fatigue, loss of appetite, nausea, difficulty sleeping, shortness of breath during physical exertion, and a swollen face. So HAPE would occur in altitudes of higher than 8,000 feet or greater, where fluids collect in the lungs, hindering passage of oxygen into the bloodstream. Signs and symptoms would be shortness of breath, cough with a pink sputum, so we're starting to bleed from the alveoli out, cyanosis, and a rapid pulse. HACE, or cerebral edema, occurs with climbers who have climbed above 12,000 feet. This may accompany HAPE and quickly become life-threatening. Signs and symptoms of HACE and HAPE may overlap with severe constant throbbing headache, ataxia, extreme fatigue, vomiting, and loss of consciousness. So the treatment would be providing oxygen, the descent from the height, transport the patient to the hospital, and if local protocol allows, CPAP may actually help this patient out. All right, lightning injuries. So approximately 49 people die each year from lightning strikes in the United States. So most of the deaths and injuries are caused by lightning occur during the summer months when people are outdoors. Lightning strikes when a massive discharge of electricity occurs between two bodies that have different charges, as you can see in this patient here. So a person need not sustain a direct hit from lightning to be injured. As you can see in the photo, you guys notice the lines throughout. So electricity from lightning is direct, not altering. So lightning injuries tend to resemble blast injuries. So damage may occur to tympanic membranes of the ears and air-containing internal organs. Muscle damage may also occur, releasing myoglobulin from injured muscles. May also jeopardize the kidneys as well, right? So you can see this patient here was struck by lightning, and you can actually see the lines as well. So for the for the cardiovascular system, lightning acts as a cosmic defibrillator. So patients that are struck by lightning can go into lethal rhythms. And it doesn't necessarily have to be cardiac arrest, but it can put them into a ventricular tachycardia as well. Right. So some regaining a pulse after a lightning strike, having respiratory arrest, is known to result from secondary cardiac arrest if left untreated. So the central nervous system is almost invariably affected by a lightning strike. So look for an entrance and exit wound as well when you're doing your assessment. So again, they may not be, it says they may be in like a ventricular tachycardia with a pulse, or could put them into a lethal rhythm shortly if struck by lightning. So cardiac monitoring, IV therapy, placing pads on the patient for quick defibrillation if the patient goes into cardiac arrest. Right. If you find them in a wide complex tachycardia, call for paramedic level backup as well. So we can start with treatments. Skin burns are usually superficial. Full thickness burns are very rare with lightning strikes. So injuries are categories from being mild, moderate to severe. And immediate life threats would be obviously anything with airway obstruction, respiratory arrest, or cardiac arrest. So the treatments really don't change with these at all. It's still going to be CPR, BVM, applying a supraglottic airway, whether it be like an LMA, King, combi tube, not combi tube, LMA, King, or an iGel. So the first priority with lightning injuries is get the patient and rescuers to a safe place. If you're in an open area and adequate shelter is unavailable, recognize the signs of impending lightning strikes and take immediate action to protect yourself. If you suddenly feel a tingling sensation on your hair stands on end, the area around you has become charged. Curl up in a ball and squat and make yourself as small target as possible. A lightning strike is apt to injure more than one person, so determine how many patients were actually injured. Reverse triage. Focus your efforts on those who are in respiratory or cardiac arrest first. Start CPR when necessary and carry out the primary survey as usual. When establishing an airway, keep in mind the possibility of cervical spine injury. Jaw thrust maneuver, and if severe bleeding is present, control it immediately. Manually stabilize the head in a neutral inline position. If the patient is respiratory arrest with a pulse, begin immediate back valve mask ventilations at 100% oxygen. If unable to effectively ventilate the patient with a BVM, insert an advanced airway device, whether it be a King, LMA, whatever you need to utilize, whatever your service carries. Provide a full spinal mobilization and transport the patient to the closest appropriate facility. Treatment of lightning strikes. Make sure the scene is safe. Priority of treatment goes to the patients who are not breathing. CPR is needed, and establish an airway and take cervical spine precautions. We're to administer supplemental oxygen, insert a large bore IV catheter, and deliver isotonic crystalloid solution wide open to keep the kidneys flushed out. Or there we can prevent kidney failure. Cover any surface burns with a dry, clean dressing, and any fractures we need to make sure we split. All right, any questions on lightning strikes? Nope. All right, moving forward. Spider bites. So bites and venomations. Spiders are numerous and widespread through the United States. The female black widow spider and brown recluse spider deliver serious, even life-threatening venom. So the spider may still be in the area, so your safety is paramount importance. So the black widow spider, female black widow, is fairly large, measuring approximately 2 inches long with its legs extended. Usually a black with a distinctive red-orange marking, as you can see right there, is in the shape of an hourglass on its abdomen. The female is larger and more toxic than the male, and found in every state except Alaska. They prefer dry, dim places around buildings, in wood piles, and among debris. The bite is sometimes overlooked, and if the site becomes numb right away, the patient may not even recall being bitten. Most black widow spiders' bites can localize pain and symptoms, including agonizing muscle spasms. A bite on the abdomen can cause muscle spasms so severe that they resemble an acute abdominal condition, and the venom is neurotoxic. Other symptoms, systemic symptoms would be dizziness, sweating, nausea, vomiting, rashes, and tightness in the chest, difficulty breathing, severe cramps with board-like rigidity of the abdominal muscles, typically developing within 24 hours. General signs and symptoms subside over 48 hours. A physician can administer a specific anti-venom. So black widow bites can be fatal in children. So with severe muscle spasms, they are usually treated in the hospital with IV benzodiazepines such as Valium or Ativan. So emergency treatment consists of BLS for the patient in respiratory distress, cleaning the bite with soap and water, and applying an ice pack to the area. Much more often, the patient will merely require relief from pain. So transport as soon as possible, and if possible, bring the spider to the hospital or take a photo of the spider with a cell phone and send it to the hospital ahead of arrival so they can start prepping. The brown recluse spider is a dull brown color, 1 inch long. The body has a violin shape mark, brown to yellow in color on its back. This is commonly called the fiddleback spider and may be found throughout the continental United States, typically found in corners of old, unused buildings under rocks and wood piles, right? in cooler areas found in closets, drawers, cellars, and clothing. The venom is neurotoxic, but is not neurotoxic, but cytotoxic. So the bite is painful. It's not painful at first, but becomes so within hours. As you can see, the wound, this bite being in the center here and spreading out with the infection. The bite rarely causes systemic symptoms and signs, but helpful if you identify the spider and either safely bring it to the hospital or take a picture on your phone and send it to the hospital ahead of arrival. Usually you'll see an ulcer that develops over the next several days in that spot. All right. So the Hymenopteria stings are painful, but not a medical emergency. So we want to remove the stinger, and it's still present, the venomous sac. This is best done by using a filmed edge item. So clean thoroughly with soap and water and use an aseptic or antiseptic solution with that. Anaphylaxis can occur or may occur. So symptoms would be flushed skin, low blood pressure, and difficulty breathing. So the patient may also have swelling to the throat and tongue. Be prepared to administer epinephrine and support airway and breathing. What is going to be our dose for epinephrine for the adult patient?
0.3.
Yeah, 0.3 milligrams. So if it is supplied in an ampule, how do we draw it up? If it's supplied in an ampule, how do we draw it up? Yeah, filter needle. Exactly. Now, do we take that filter needle and then inject that into the patient, or do we swap out needles? Yeah, swap them out. And where do we administer the medicine? Where do we administer? The thigh. And be more specific, it'd be the lateral thigh. Whether it be right or left doesn't matter. All right, awesome. All right, so snake bites. Snakes. All right, so fatalities in the U.S. are extremely rare. So one of the approximately 115 different species of snakes in the U.S., only 19 are venomous. The rattlesnake, copperhead, cottonmouth, or water moccasin, and coral snakes. So this figure here shows the venomous snakes. So we have the rattlesnake here, right? The copperhead, the cottonmouth, and then over here is going to be the coral snake. So the cottonmouths are often rather aggressive. Rattlesnakes are easily provoked. Coral snakes usually bite only when they are being handled. So use extreme caution on snake bite calls. Wear proper protective equipment, so the amount of toxin injected is directly related to toxicity. Only 1/3 of the snake bites result in substantial local or systemic injuries. Not a lot of places in Maine carry antivenom. Some people out there illegally may have poisonous snakes in their homes, and they may get bit. I haven't seen many poisonous snake bites, and most of them have been interfacility transports. And I had one that I got bit at Maine Medical Center and had to do an emergency transfer to New York City, where the closest antivenom was. I did that with the critical care team. So that was a long drive going down to New York. But that was the closest antivenom. And it was a snowstorm, so they couldn't get the antivenom up. So we had to get the patient down to them. So venomous snakes native to the United States all have hollow fangs in the roof of their mouth that inject the poison from 2 sacs on the back of the head. I'll show you guys this as well in the next slide. The non-venomous snakes can also bite, leaving a horseshoe-shaped teeth marks. So some venomous snakes have teeth as well as fangs. So a person bitten by any venomous snake needs prompt transport. So notify the hospital as soon as possible if the patient has been bitten by a viper or a coral snake, a pit viper or a coral. So you look at this one here. Pit vipers. So a pit is a heat sensing organ that allows a snake to strike at any warm target. So rattlesnakes, copperheads, and cottonmouths are all pit vipers with a triangular shaped flat head. The pit is a heat sensing organ, which we talked about. The fangs of the pit viper normally lie flat against the roof of the mouth, as you can see in this photo here. When the snake strikes, the mouth opens wide and the fangs extend. The fangs are special hollow teeth that act similar to hypodermic needles. So the primary purpose of the venom is to kill small animals and start the digestive process before they are eaten. There are several different species of rattlesnakes that can be identified by the rattle on the tail. So when agitated or endangered, rattlesnakes shake their tails or rattles. Copperheads are similar than rattlesnakes, or somewhat smaller than rattlesnakes. So cottonmouths grow approximately 4 feet in length. Water snakes are a particularly aggressive pattern of behavior. So the tissue destruction from the venom may be severe. The signs of envenomation by a pit viper would be the burning pain at the site of the injury, swelling, bluish discoloration and light skin on light-skinned people will be a bluish discoloration. So the venom can also interfere with the body's blood clotting mechanisms as well. Other systemic signs would be weakness, nausea, vomiting, and vision problems, along with seizures, sweating, fainting, changes in level of consciousness, and shock. So the smaller the patient, the more severe the symptoms are more likely to be. So if swelling has occurred, use a marker to mark its edges on the skin to kind of see if you can see any trending or if it starts to get worse and starts spreading. Yeah, I agree. So coral snakes are small reptiles with a series of bright red, yellow, and black bands completely encircling the body. They live mostly in the southern states and the Southwest, and they are relative of the cobra. They have tiny fangs and inject venom with their teeth by a chewing motion. This leaves one or more punctures or scratch-like wounds. Usually bites its victim on a small part of the body. So coral snake venom causes paralysis of the nervous system. Often they are limited and there are no local symptoms. Treatments of the snake bites would be the steps of treating emergency care for pit vipers and coral snakes are similar. So when treating a bite from a pit viper, you got to calm your patient down, have the patient lie supine, and explain that remaining still and calm will slow the spread of any venom throughout the system. Determine the approximate time in the bite and document the time en route to the receiving facility. Clean the bite area gently with soap and water or a mild antiseptic, and do not apply ice. If a bite occurred on the arm or leg, consider the use of a pressure immobilization bandage, and then place the affected extremity below the level of the heart. Be alert for anaphylactic reaction to the venom and treat with an epinephrine auto-injector pen, or because you're working as an advanced EMT, you can drop the epinephrine through an ampule, administer that way. Do not give anything by mouth and be alert for vomiting. If the patient was bitten on the trunk, keep the patient supine and calm and transport as quickly as possible. Right. So monitor the patient's vitals and mark the skin with a marker. As you can see, they marked up here, so in that area, and they're going to check and see if it starts to spread. If signs of shock are present, place the patient supine and administer 100% oxygen. Be prepared to assist ventilation if needed. Initiate IV therapy according to local protocols. If the snake has been killed, bring it with you or take a photo of it on your phone. Notify the hospital that the patient has been bitten by a snake. If possible, describe the snake to them and transport promptly. Call paramedic backup if needed. Successful treatment depends on positive identification of the snake in support of vital central nervous system functions. Antivenom is available for coral snake bites, but most hospitals do not stock it. You have to notify the receiving hospital as soon as possible so they can try to locate where it is. If the patient shows no signs of envenomation, provide BLS care, place a sterile dressing over the suspected bite area, immobilize the injury site. All patients with a suspected snake bite should be taken to the emergency department whether they show signs of envenomation or not. All right, so we're almost there. Scorpions, the eight-legged arachnids from the biological group Arachnia, are found primarily in the southwestern United States and in deserts. Stings are usually very painful but not dangerous, causing localized swelling and discoloration. The venom may produce severe systemic reaction, causing circulatory collapse if it is one of the venomous ones, severe muscle contractions, excessive salivation, hypertension, seizures, cardiac failure. Antivenom is available if you make it to the hospital in time. So notify medical control as soon as possible and administer BLS and provide rapid transport to the ED. All right, ticks. Usually attach themselves directly to the skin and can be easily mistaken for a freckle. The bite is not painful, but danger from the infecting organism that the tick carries. Most common tick-borne diseases are Lyme disease, as well as, I'm going to try to pronounce those, but Rocky Mountain spotted fever. So diseases are spread through the tick's saliva. So the longer the tick stays embedded, the greater the chance the disease will be transmitted. Rocky Mountain spotted fever occurs within 7 to 10 days after the bite and is by an infected tick. Usually symptoms would include nausea, vomiting, headache, weakness, paralysis, and possible cardiorespiratory collapse. Lyme disease are symptoms or fever or flu-like symptoms and a rash that may spread to several parts of the body. They resemble like a target or a bullseye pattern, as you can see on the leg here. This may be confused with rheumatoid arthritis, and if treated promptly with antibiotics, the patient may recover completely. Tick bites occur most commonly during the summer months. All right, I've known people that have had or was diagnosed with rheumatoid arthritis, and they went and got checked out years later, and they just for the hell of it did a Lyme disease check, Lyme disease, and all the pain went away. So again, it's crazy stuff. Lyme disease, small little ticks. So transmission of infection from a tick to a person takes at least 12 hours. So to remove a tick, you want to use tweezers. We're going to grasp the tick by the head and pull gently but firmly straight up. Cleanse the area with antiseptic. Save the tick so that it can be identified, and do not handle the tick with your fingers. All right, so get this, put them in like a glass jar, bring them to the hospital with you so they can test it. All right, so injuries from marine animals and other animals that as well. So stinging cells and systemic symptoms include headache, dizziness, muscle cramps, and fainting. So jellyfish, things like that. If you get stung by a jellyfish, right, remove the patient from the water and remove the tentacles by scraping them off with an edge of a stiff object. Wash the affected area with vinegar immediately and available for at least 30 seconds. Please do not pee on your patient. Yes, urine can also reduce the burning sensation. I would highly recommend that you don't do that. To limit further discharge of the nematocysts by avoiding fresh water, wet sand, showers, and careless manipulation of the tentacles. Reduce the motion of the affected extremity, and if persistent pain, may respond to immersion of the area in hot water for 30 minutes as well. So a patient may have a systemic allergic reaction to the sting of one of these animals. So treat the patient for anaphylactic shock as needed. So toxins from the spines, urchins, stingrays, or certain spiny fish are also heat sensitive. So the best treatment to immobilize an affected area is soak in hot water for 30 minutes. If you work near the ocean, you should be familiar with marine life in your area. All right. Any questions?